I will be presenting. So Frances is our consultant midwife, and she's one of our team members for that project, and was also working very closely with Melissa Fox-Black, who is a safeguarding midwife, for setting up this project, the Olive Clinic. So the background of the project is really based on women's voices. In the summer 2023, our consultant midwife Frances, who is present here, attended a focus group of Albanian-speaking women who shared some challenges that they had in accessing care and navigating healthcare pathways. They also shared their frustration over the lack of continuity of care, meaning that they had to repeatedly explain their situation to different healthcare professionals. Some of them needed to use the interpreting services, and they were concerned about the quality of the telephone interpreting services. They were also worried about the confidentiality of those services, but also some of the women were really uncomfortable with having to use a male interpreter. Some feedback as well was that there was a lack of written information in Albanian, and sadly, some women had reported negative experiences due to staff attitude, but also due to lack of trauma-informed care and cultural aware care. So that gave us some insights on how we could maybe focus on an improvement with our service. But to understand better what was happening at Kingston Maternity Unit, we reviewed the data. So we had a look at 108 medical record of women who have given birth within 22 months before the Green Maternity Challenge. And it is important for us to have a look at this, because we wanted to confirm what the women had reported on that focus group. So what it confirmed is that yes, we could improve continuity of care. We had only 43% of our women who had continuity of care through their pregnancy. One in three women who had booked with us had limited English proficiency, which means that they needed to use interpreting services. And as you can see below, only 19% of those women had a consistent use of the interpreting services throughout their pregnancy. And then another thing that was kind of important is that we collected data on social, economic, and mental health issues, and we noted that 1 in 4 of these women had such issues. And we're talking about women who had been victim of human trafficking, sexual exploitation, women who had asylum-seeking status, lack of permanent accommodation, also women who had suffered of traumatic stress disorder, pain. So there was a lot for us to address, and we thought that this population was quite vulnerable and needed some more support. What was also important for us, and I forgot to mention that right at the top of the slide, is that although Albanian represent about 0.2% of the UK population, at Kingston they do represent 1% of our bookings. So we performed a very thorough literature search, and again, it brought to light what we already all know, that socioeconomic, cultural, and communication barriers can hinder access to maternity services, and it can also lead to poorer health outcomes for women and their babies. And that includes higher rates of stillbirth, neonatal mortality, preterm birth, fetal growth restriction, as well as increased maternal morbidity. And that was really, really important for us to understand how we could change this into improving care for these women. So again, the literature search helped us understanding that barrier to access timely and appropriate healthcare will lead to delayed interventions and poorer outcomes for moms and for babies. And that means that we then have a reactive approach where we have a more intensive and resource heavy approach to healthcare. And as you can see on the right, this means that this is not a sustainable way of running our healthcare services. In terms of our finances, it's going to increase strains on financial and operation resources. It will also exacerbate workforce pressures. And if we're thinking of our users, the women who are using our services, this will reduce trust in our healthcare services, which means that people are less likely to address healthcare services when they need it. And again, we're entering this vicious circle of having again a reactive approach because of delayed interventions and poorer outcome. So our project is all about empowering women with taking care of their health and theirs of their baby, but also with preventing disease. So what we wanted to do is provide equitable healthcare and patient empowerment. We know that this can lead to timely interventions if they are needed and improve outcomes. And as a result, it will reduce the need for intensive and resources heavy treatments. So as you can see here, it's a way more sustainable way of leading healthcare services because again, we are going to mitigate strains on financial and operational resources, mitigate workforce pressures, and improve patients' experience, which means they feel more comfortable to come to us if they are worried. So our proposal was to pilot a new clinic for Albanian-speaking women booked at Kingston Maternity because they are a very vulnerable population, and they had already told us how we could help them. And the idea that we had was to set up a continuity of care clinic, a midwifery clinic, with the support of our safeguarding midwife Melissa. The additional support that we would have would be to have a female face-to-face interpreter who would be present during the clinics. And we also wanted to have written information in Albanian that would be accessible through our website. So that was our first step in the timeline of 12 months. So we wanted to set this up within 6 months. And then with the view of improving the service, we also wanted to set up antenatal classes, whereas they would be face-to-face or remote virtual antenatal classes. And with a long-term plan, we were thinking also of improving the labor care by exploring the provision of working with a doula, an Albanian-speaking doula, who could provide more support for these women who are quite often isolated. So
Sorry,
the
you've just got about 30 seconds left.
Oh my God. Okay. So basically, we have started a clinic in November 2024. We've got 16 women who have been seen. 100% have had continuity of care with Melissa. We have had a face-to-face female interpreter to support the clinic. No appointments were missed, and we've been able to provide information on our website. And women's feedback has been overwhelmingly good, although it is quite small because our sample is so small. We women are very positive about continuity, about the interpreting services and the overall service, and we're really pleased that the people who had answered our survey did say that they would recommend the clinic to all Albanian-speaking women that they would have as friends. So our learning really is that women's voices did drive the change. We have the data collection was really time consuming, but that was really helpful with the project. And having the teamwork and managerial support was really crucial to lead the project. And obviously, there was a lot of learning about carbon footprinting of our maternity pathways. And finally, our next step will be to secure fundings to continue the clinic, implement the antenatal classes, continue looking for a doula interpreter, and collecting women's feedback so that we can continue improving the pathway. Thank you.
Thanks, Green. I'm so sorry to rush you at the end.
It's me.
Are there any questions from the judging?
I'll come in here. That's a really interesting presentation, and I'll ask you a question that gives you a bit more time to elaborate on that last bit round about the kind of next steps. What do you see in terms of what might work well, what the challenges might be, and if there's any kind of transferable learning for other groups of women, particularly other non-English speaking women. What can others learn from your experiences?
Thank you. Yeah, I think so. Having the focus group to start with has been very, very helpful because although it is important to have the data, it is important to hear the women you are providing the care for in your local area because statistics are usually across the entire country or across the globe. So that was really important to us. And what we want to do is, complete this pilot and again regroup with the women to see what has worked well and what we could improve in the future. And once we have done that, I think we can start extrapolate it. But we need to collect this information before we're giving some suggestions to other teams. But overall, at the moment, really, it's been overwhelmingly positive.
Thanks, Green. Any other questions from the judging panel?
I had a question about the local Albanian community. I think I know you sort of identified that quite a lot of the women are isolated, but I just wondered whether there are community organizations, groups, or support networks that you're also engaging with or could be strengthened alongside the direct provision of care, if you see what I mean.
Yeah, thank you for your question. So our safeguarding midwife Melissa, who couldn't be present today on the call, has very strong connections with support groups for women, and she's the one who is in charge of basically connecting the women with those associations. But yeah, she's got a network that she's already working with, and she's been working with for quite a while. And actually, when we were looking for this project, the feedback from the focus group was one part of one of the kind of catalysts for the project. But there was also the feedback from Melissa having to do additional referrals for these women, and again wasting maybe using time that we could have used in the continuity of her care clinic, as opposed to staff needing to do additional referrals if they were being seen in the antenatal clinic. So Melissa is leading on that, basically.
Thank you.